Glare. Environmental, optical, and ocular causes. Glare is commonly described as difficulty seeing, discomfort, or reduced visual performance in the presence of a bright stimulus. Clinically, however, glare is not a single phenomenon and is not a diagnosis.
Can you see your face?
It's certainly more clear, it looks like, in the light, and despite the fact that there's absolutely no normal light in here, I can see the entire smile, the cheeks, the dimples, the nose shape, the forehead, the eyebrows very, very clearly. The colour of the eyes is still not very evident, but I can see the shape, and and I can see that it's blue.
Could you put the blue in now? See what happens to your face.
The eyes have gone again, and I can still see from the nose downwards.
The term can refer to different visual responses arising from the interaction between the light stimulus, the environment, the optical media of the eye, ocular pathology, retinal function, and visual processing. Two major clinical categories are disability glare and discomfort glare. Disability glare refers to degradation of visual performance caused principally by stray light. Light scattered within the eye produces a veiling luminance over the retinal image and reduces image contrast. Discomfort glare is different. It describes an unpleasant visual response to illumination and does not necessarily correspond to an equivalent reduction in visual performance. These mechanisms can coexist, but they should not be assumed to be the same. Glare complaints can therefore arise from environmental conditions, optical factors, ocular disease, or combinations of these. The appropriate intervention depends on identifying the underlying mechanism. Environmental glare. The first source of glare is the visual environment. Environmental glare is determined not simply by the absolute amount of light, but by its distribution within the visual field. Important variables include luminance, luminance contrast, source size, source position, background luminance, spatial distribution of illumination, and the state of visual adaptation. A bright source viewed against a dark background produces a substantially different visual stimulus from the same source viewed against a bright background. This is particularly relevant at night. A vehicle headlamp may have a very high luminance relative to the surrounding road. The resulting luminance difference can produce substantial visual disturbance even though the headlamp occupies only a small proportion of the visual field. The problem can therefore be considered in terms of luminance distribution and contrast, rather than simply brightness. Direct glare. Direct glare occurs when a luminous source is within the observer's visual field. Examples include the sun, vehicle headlights, high luminance LEDs, illuminated signs, windows, and poorly positioned luminaires. The effect depends on both the source and the surrounding field. A small, high luminance source against a dark background can be particularly disruptive. Environmental measures can therefore include reducing source luminance, shielding the source, increasing its emitting area, altering its position, or modifying the surrounding illumination. The appropriate intervention is determined by the source of the problem. Reflected glare. Glare can also result from reflected light. Common sources include water, snow, wet roads, glass, polished surfaces, vehicle surfaces, windscreens, and display screens. The characteristics of the reflecting surface determine the distribution of the reflected light. Smooth surfaces produce predominantly specular reflection and can generate relatively well-defined images of bright sources. Wet roads provide an important example in night driving. Headlamp illumination can be reflected from the road surface and contribute additional luminance to the visual field. The intervention in this situation may involve modifying the source, the reflecting surface, the viewing geometry, or the optical pathway. Polarization can reduce some forms of reflected glare, particularly from surfaces such as water and roads, but it does not address intraocular scatter or ocular pathology. Reflections from screens and optical surfaces. Modern visual environments contain numerous reflective optical surfaces. These include windscreens, spectacle lenses, windows, computer screens, glass doors, display cases, and glossy printed material. A screen may have adequate intrinsic luminance and contrast but still become difficult to view if it reflects a window or luminaire. The reflected image is superimposed on the intended retinal image and can reduce effective contrast. This is a form of veiling reflection. In such circumstances, changing the screen position, controlling the illumination, reducing reflections, or modifying the surface may be more effective than increasing screen luminance. Adaptation and luminance transitions.
Looking at someone from the back, I find that I can recognise them, and I find that strange because there's not, but maybe it's because there's too much detail at the front.
Visual performance is also influenced by adaptation. The visual system adjusts continuously to changes in ambient illumination. A bright stimulus viewed after adaptation to darkness produces a substantially different visual response from the same stimulus viewed after adaptation to a high luminance environment. This is particularly relevant to night driving, tunnel entrances and exits, transitions between indoor and outdoor environments, and rapidly changing illumination. The temporal characteristics of the transition are therefore relevant as well as the absolute luminance. Glare should consequently be considered in relation to both spatial and temporal luminance distribution. Optical sources of glare. Light entering the eye passes through several optical media. Tear film to cornea, then through the aqueous humor and crystalline lens, passing through the vitreous and eventually the retina. The ocular media are not perfectly transparent. Light can be scattered within them, producing ocular stray light. Stray light represents light reaching retinal locations away from the geometrical image of the source. It can produce a veiling luminance over the retinal image and reduce contrast. Disability glare is closely associated with this process. The distinction between stray light and optical aberration is important. Aberrations primarily affect the central part of the optical point spread function and can produce blur, halos, starbursts, and ghost images. Stray light has a wider angular distribution and contributes particularly to contrast loss and disability glare. These are related but distinct optical phenomena. The cornea. The cornea is the principal refractive surface of the eye. Its transparency and regularity are therefore critical to optical quality. Corneal abnormalities can alter the retinal image through several mechanisms, including light scatter, irregular refraction, higher-order aberration, and changes in the anterior optical surface. Conditions that may produce these effects include corneal scarring, keratitis, corneal edema, corneal dystrophies, keratoconus, other corneal ectasias, recurrent epithelial disease, and traumatic or surgical corneal changes. Patients may describe the resulting visual disturbance as glare, haze, halos, ghosting, or reduced visual quality. The terminology used by the patient does not, by itself, establish the underlying optical mechanism. The tear film and ocular surface. The tear film forms the first optical surface of the eye. Tear film instability can therefore affect image quality directly. In dry eye disease and other ocular surface disorders, changes in the tear film can produce temporal variation in the optical quality of the eye. Patients may experience fluctuating vision, blur, ocular discomfort, photophobia, visual fatigue, and glare. Ocular surface disorders therefore represent another potential source of light-related visual symptoms. The appropriate assessment is directed towards the ocular surface rather than assuming that the primary problem is environmental illumination. The crystalline lens and cataract. The crystalline lens is a major source of ocular scatter, particularly when its transparency is reduced. Cataract is one of the most clinically important ocular causes of glare disability. Cataract can increase intraocular stray light and reduce visual quality, producing symptoms including glare, halos, reduced contrast, hazy vision, and difficulty seeing under bright or low contrast conditions. The relationship between visual acuity and stray light is not straightforward. Visual acuity and stray light represent substantially different aspects of optical quality and can vary relatively independently. A patient can therefore have reasonably good high contrast acuity while experiencing substantial disability from glare. This is clinically important because a conventional acuity measurement does not fully describe functional vision under conditions of glare. The significance of cataract is therefore not determined exclusively by the number of lines lost on an acuity chart. Posterior capsule opacification and pseudophakia. Glare and other quality of vision disturbances can also occur after cataract surgery. Posterior capsule opacification can reduce visual quality and produce symptoms including glare and reduced contrast. In pseudophakic patients, other optical phenomena can also occur, including dysphotopsias associated with intraocular lenses. These symptoms need to be distinguished from disability glare caused by increased ocular stray light. The clinical assessment should therefore consider the optical status of the pseudophakic eye rather than assuming that all postoperative glare has the same cause.
Yeah, don't like it.
And do you get headaches at all with that?
Yeah, and I feel kind of always sometimes feel when I'm going into the Kyle Centre as if I'm no well.
Ocular inflammation. Light sensitivity is also a recognized feature of ocular inflammation. Anterior uveitis and iritis, for example, can produce photophobia, pain, blurred vision, and ocular discomfort. A patient may describe the problem as intolerance of bright light or glare. However, this is not equivalent to disability glare caused by intraocular stray light. The underlying mechanism includes inflammatory activation of ocular sensory pathways. This distinction is clinically important because the appropriate response is investigation and treatment of the inflammatory disorder rather than simply reducing illumination. Glaucoma and corneal edema. Certain acute ocular conditions can produce halos or marked light sensitivity. In acute angle closure glaucoma, for example, patients may report blurred vision and halos around lights, usually in association with other symptoms such as significant ocular pain. Corneal edema can alter the optical transmission of the cornea and contribute to the appearance of halos. This is an example of why a report of halos or glare must be interpreted in its clinical context. The symptom itself does not establish the diagnosis. Iris and retinal conditions. Abnormal control of retinal illumination can also produce marked light sensitivity. Conditions such as aniridia, iris transillumination, and albinism can increase the amount of light reaching the retina or alter its distribution. Some retinal disorders can also produce abnormal light sensitivity or impaired adaptation. Retinal disease may additionally reduce contrast sensitivity, making visual performance under bright or complex illumination more difficult. These effects should not automatically be classified as optical glare. The relevant mechanism may be retinal dysfunction rather than increased ocular stray light.
When you lit it with certain colours, it made it very easy to read, and I could read almost to the bottom line, especially with green in the background. When you introduced red, when it was totally red, I found it absolutely repellent. And when you did introduce some red, the bottom 3 lines they weren't readable, they were just blocks of red. All I could see was a solid block of red and couldn't make out any letters.
Other ocular causes of light sensitivity. Other ocular conditions associated with photophobia or light-related visual symptoms include photokeratitis, ocular surface inflammation, corneal epithelial disease, severe dry eye disease, and some postoperative or post-traumatic optical disturbances. Again, these conditions do not necessarily produce disability glare in the strict physiological sense. They demonstrate, however, that light sensitivity and glare complaints can have multiple ocular causes. Glare, photophobia, halos, and aberrations. Clinical terminology needs to be used carefully. Disability glare refers to impairment of visual performance associated with stray light and loss of retinal image contrast. Discomfort glare refers to an unpleasant response to illumination and does not necessarily imply equivalent loss of visual performance. Photophobia refers to abnormal or excessive sensitivity to light and has multiple possible ocular and neurological causes. Halos are luminous rings or zones surrounding bright sources. Starbursts are radial extensions from bright sources. Ghosting describes displaced or duplicated image components. Haze describes a reduction in visual clarity or transparency. These phenomena can coexist. They should not, however, be assumed to have a common mechanism. Pattern glare. Pattern glare is different from glare caused primarily by excessive luminance. The relevant stimulus is the spatial organization of the pattern. High-contrast repetitive patterns, particularly stripes and gratings, can produce visual discomfort or perceptual disturbance in susceptible individuals. Relevant stimulus characteristics include spatial frequency, contrast, orientation, pattern geometry, and the spatial arrangement of the elements. Reported effects can include discomfort, apparent movement, shimmering or distortion. Pattern glare should therefore be considered separately from disability glare produced by intraocular stray light. It is a visual response to the structure of the stimulus rather than simply its luminance. The relationship between pattern glare, migraine, and visual discomfort has been investigated, but these terms should not be treated as interchangeable diagnoses. Spectral characteristics. Light sources also differ in their spectral distribution. Sunlight, LEDs, fluorescent sources, and vehicle lighting can have substantially different spectral compositions. Spectral characteristics influence color perception, chromatic adaptation, and the retinal response. They may also interact with ocular optics, including chromatic aberration. However, it is not scientifically justified to conclude that a particular wavelength is intrinsically responsible for glare. The effect of a spectral filter depends on the spectrum of the source, the transmission spectrum of the filter, the surrounding illumination, and the visual task. A filter therefore changes the stimulus reaching the eye, it does not automatically correct the underlying cause of glare. Tinted lenses will be considered separately. Disability glare and visual acuity. One of the most important clinical points is that visual acuity does not fully describe visual performance under glare conditions. High-contrast acuity testing measures the ability to resolve relatively small, high-contrast targets under controlled conditions. Real-world visual performance is more complex. It may involve low-contrast targets, large luminance differences, reflections, bright point sources, changing adaptation, optical scatter, aberrations, and complex backgrounds. Consequently, a patient can have good measured acuity but substantial functional difficulty in glare. Studies of cataract and ocular stray light demonstrate that acuity and stray light are relatively independent measures of visual quality. This is one reason why contrast sensitivity, glare testing, stray light measurement, and optical assessment can provide information not captured by visual acuity alone. Multiple mechanisms may coexist. In clinical practice, glare is rarely required to have a single contributing factor. Consider night driving. The visual stimulus may consist of a high-luminance LED headlamp against a low-luminance background. The windscreen may produce reflections. The spectacle lenses may introduce additional reflections. The pupil may be relatively large. The eye may have increased intraocular stray light. The cornea may contain optical aberrations. The crystalline lens may have early cataract. The visual system may also be adapting to darkness. These factors can act simultaneously. The resulting complaint may simply be described by the patient as glare. The clinical task is to determine which mechanisms are actually present. Clinical assessment. A complaint of glare should therefore lead to assessment of both the visual stimulus and the eye. Relevant questions include: when does the problem occur? Is it predominantly during daylight, twilight, or darkness? Is it associated with particular light sources? Does it occur with reflections? Is it present with screens? Does it occur with repetitive visual patterns? Is there associated pain? Is there photophobia? Are there halos or starbursts? Is there ghosting or monocular diplopia? Is vision fluctuating? Is the problem unilateral or bilateral? Has it developed following ocular surgery or trauma? The ocular examination should consider the ocular surface, cornea, anterior chamber, crystalline lens or intraocular lens, vitreous and retina, as clinically appropriate. Optical correction and pupil-dependent aberrations may also be relevant. Where appropriate, additional assessment can include contrast sensitivity, glare testing, stray light measurement or aberrometry. No single test provides a complete description of glare-related visual function. Choosing the intervention. The intervention should follow the identified mechanism. For environmental glare, modify the source or its spatial relationship to the observer. For reflected glare, reduce or redirect the reflection. For inappropriate luminance distribution, modify the lighting environment. For reflections from optical surfaces, improve the optical pathway. For tear film instability, assess and manage the ocular surface. For corneal pathology, investigate and treat the corneal disorder. For cataract or other media opacity, assess the clinical significance of the opacity and treat when indicated. For ocular inflammation, investigate and treat the inflammatory disease. For optical aberration, assess the optical system and determine whether appropriate correction is possible. For pattern-related visual discomfort, modification of the visual stimulus may be appropriate. For selected forms of reflected glare, polarization can be useful. Spectral filters may have specific applications, but their effect should be assessed against the actual visual problem rather than assumed from their color alone. Tinted lenses. Tinted lenses deserve separate consideration because they are frequently proposed as a treatment for glare. A tint reduces the spectral and photometric content of the light reaching the eye. Whether that is beneficial depends on the stimulus and the underlying mechanism. A tint cannot remove a cataract. It cannot eliminate corneal scatter. It cannot correct an irregular cornea. It cannot treat ocular inflammation. It cannot remove reflections generated by a windscreen or spectacle lens. And reducing retinal illumination can have disadvantages, particularly under mesopic or scotopic conditions. The appropriate question is therefore not which tint treats glare. It is, does modifying the spectral and luminance characteristics of the stimulus improve visual function for this particular person under these particular conditions? That is a much more clinically useful question. Tinted lenses will be considered in detail in a separate video. Glare is a heterogeneous clinical complaint. Its causes can be environmental, optical, ocular, or perceptual, and more than one mechanism may be present in the same patient. Environmental glare is influenced by luminance, contrast, source position, spatial distribution, and adaptation. The appropriate approach is therefore to identify the stimulus, the optical pathway, the condition of the eye, the resulting retinal image, and, where relevant, the subsequent visual processing. Only then can an appropriate intervention be selected. Glare should therefore be treated as a clinical symptom requiring identification of its mechanism, rather than as a single visual disorder with a single treatment. The objective is not simply to reduce light. It is to identify why the visual system is performing poorly or why the light is producing discomfort, and to intervene at the appropriate point in the system.